Hello, my name is Bipin Phillip. I'm a pediatric emergency medicine physician at UPMC Children's Hospital of Pittsburgh. Today, we will discuss how to place a peripheral IV under ultrasound guidance. In this lecture, we will go over fundamental principles for ultrasound-guided IV access. These principles can be useful for any future ultrasound-guided procedures you might want to learn. We will discuss technique, setup, supplies, and common pitfalls. IV placement is a critical procedure in the emergency room. It allows for prompt vascular access in the critically ill child. It also allows for blood sampling for diagnostic testing. Before reviewing the procedure, let's go over some basic terms. As a beginner, orientation on screen can be confusing, but will become more familiar with time. For IV access, there are two views to remember. Long axis or in plane as we see here, and short axis or out of plane as we see in the second image. The long axis view lines the ultrasound beams in a way that allows us to see our desired object in the long axis or in plane. Every ultrasound probe has a marker, which is usually a small raised notch on its side. This marker should be aligned with the marker on the machine's screen. For the in-plane approach, we will direct the probe toward the patient's head until we see the vein in the long axis. This cartoon depicts how the ultrasound beams line up with the vessel in the long axis. This view allows us to direct the needle in an in-plane approach. Although this makes it easier to visualize the needle throughout the procedure, it is a technically more advanced skill. The short axis or outer plane view is obtained by a 90-degree turn from the long axis. This lines the ultrasound beams in a transverse axis to our desired object. We will direct the probe toward the patient's right until we see the vein in the short axis. The needle appears as a bright white dot as seen in this clip. As the probe is rotated 90 degrees, we see the vein in short axis. In this lecture, we will focus on the short axis or out of plane technique. Once you have mastered this, the in-plane technique is a worthwhile skill to pursue for the advanced sonologist. Echogenicity refers to an object's ability to reflect ultrasound. An ultrasound machine displays an image on a grayscale based on degrees of echogenicity. Objects like fluid-filled vessels are not very echogenic and will not reflect much sound back, thus appearing black or anechoic. Objects like bone are highly echogenic and will reflect most or all sound back, thus appearing white or hyperechoic. Tissues vary in its echogenicity and will be displayed on this grayscale. Note here the muscle appearing gray or hypoechoic. The angle of intonation is an important concept to remember for ultrasound-guided IV placement. It is the angle of the ultrasound beam relative to the object, in this case a needle. The closer the ultrasound probe is to 90 degrees with the needle, the stronger the reflected beams are, and thus the better the needle will be visualized. This cartoon shows how if the ultrasound beams are not perpendicular, the reflections can scatter and thus weaken the image on the screen. A small tilt of the probe toward the operator, as shown in this video, can improve the image quality of the needle. We will now talk about preparing for the procedure. Like all procedures in medicine, preparation is the key to success. Superficial structures like veins are best visualized with high-frequency ultrasound. Therefore, a high-frequency linear probe is the best choice for this procedure. Next, gather the necessary equipment. Being prepared helps you have maximum control over the procedure and environment. Being prepared also helps the parent feel confident in your skills. Before beginning, we must identify an adequate vessel. It is helpful to have a general idea of patient-specific vessel anatomy. As you see in this video, scan along the arm to trace the path of the vein. Make a mental note of the area on the arm where the vessel has the straightest path. Also make note of any nearby structures like arteries or nerves. Take note of depth changes, turns, and bifurcations of the vessel. The upper extremities are common sites for IV placements. There are many veins to choose from and include the cephalic, basilic, and median cubital veins. The lower extremity has the great saphenous vein, which is also a good option in the patient with difficult access. Veins can be identified as easily compressible anechoic structures without pulsatility. In this picture, the red circle shows a pulsatile artery and the blue circle shows a compressible and non-pulsatile vein. The final preparatory step is to properly position yourself, the patient, the holder, and the equipment. As seen in this picture, a very young patient can be safely papoosed while exposing the extremity. Position the arm straight and extended towards you. A towel roll can help straighten the arm and allow for mild hyperextension at the elbow. This keeps the skin taut and minimizes vessel rolling during the procedure. The machine should be placed in your direct line of vision, and the screen must be visible to you without having to turn your head much. Having the machine on the other side of the bed, across from you, is also a good way to accomplish this. A holder is key to the success of this procedure in the young pediatric patient. They should stabilize at the elbow or shoulder and the wrist for maximal control and safety. A pacifier and parent presence can also help calm a scared child. Now for the procedure. Hold the needle with your dominant hand while using your non-dominant hand to hold the probe. Hold the probe at the neck with your first 3 fingers and use your last 2 fingers and the base of your hand to stabilize the probe on the patient. Holding the probe this way with your first 3 fingers helps with fine motor control. Now, re-identify the previously chosen vein and line it up at the center of the screen. The center of the screen correlates with the center of the probe, and so line up your needle in the middle of your probe. With the vessel in the middle of the screen and the needle at the center of the probe, penetrate the skin at about 45 degrees. As soon as you've broken skin, find the needle tip by rocking the probe toward you. This optimizes the angle of intonation. Once you see the needle as a white dot on the screen, walk your probe away until the white dot vanishes. See, walk, vanish. See the needle, walk the probe until the needle vanishes. Only then should you advance the needle in the patient's arm. We will discuss this critical point further in the pitfall section. Advance the needle until you see the needle tip in the vein. At this point, flatten the angle of the needle on the patient's arm. Keep the white dot in the middle of the vessel and continue the see, walk, vanish steps until the needle is hubbed to the skin. At this point, the probe can be set down. The IV has been successfully placed. However, the work is not done. Please take a moment to notice the clip on the left. Notice the white dot appearing in the vein. This is the see, walk, vanish technique in action. Once I see the dot on the screen, I slide my probe away from the needle on the patient's arm until the dot disappears. The needle is then advanced in the vein until it is back in the field of view of the ultrasound probe. Adequate control over the catheter must be maintained at all times. It is easy to let your guard down here, and a wiggly child can quickly undo your efforts thus far. Anchor the catheter in place with your non-dominant hand. Now, use your dominant hand to clean off gel and any blood and attach the tubing. Your holder can help with this. Once the area is dry, the catheter can be secured in place with tape. Now the job is done, and you have a functioning IV in place. There are 2 important pitfalls to keep in mind: not visualizing the needle tip during the procedure and not securing the IV catheter after the procedure. It is important to have your supplies ready to secure your IV catheter. It is easy in the moment to inadvertently have your needle slide out, particularly when the patient is uncooperative or there is a lot of gel or blood in the field. Be careful to have gauze ready and to only use the minimum amount of gel necessary. It is critical to always visualize the needle tip before advancing your needle. Not confirming the tip can cause you to advance past the vessel wall as seen in this video. The cartoon on the left helps us understand why. Imagine that each probe is connected to a separate ultrasound machine. Since we are in short axis, Each of the 3 probes will depict a hyperechoic white dot on the ultrasound screen. You cannot therefore be sure which one is at the tip based on its on-screen image. If, however, you move the probe along the needle until the dot disappears on the screen, you can be sure that the point immediately before it disappears is the needle tip. This is your only cue to advance the needle. See, walk, vanish. In summary, ultrasound is a useful tool for the successful placement of peripheral IVs in the emergency department. The short axis or out-of-plane approach discussed here can be quickly mastered. Preparation is key. Have your supplies and a good holder ready. Remember, see, walk, vanish. Always visualize the needle tip before advancing your needle. I hope this short lecture was a helpful introduction to the basics of ultrasound-guided IVs. As with any procedure and ultrasound skill, practice makes perfect. Thank you for your attention and happy scanning.